Hello and welcome back. So this is the next part of our lecture on abnormal vaginal discharge, and we will start with investigations which can be performed for pelvic inflammatory disease. First is there are some routine tests which are not specific to pelvic inflammatory disease. So we can start by doing a complete blood count. So mainly we are interested to know, yes, we will have a look at the hemoglobin, but we want to see what is the white cell count. Again, even if its white cell count is high, it may be because of some other reason, right? It does not necessarily mean that it is pelvic inflammatory disease, but it just gives us a rough idea, but it's non-specific. Then we can also, of course, perform C-reactive protein. ESR these days is less commonly performed, but C-reactive protein, if it is high, then it tells us the severity, right? So it may be severe pelvic inflammatory disease. As we said, sometimes pelvic inflammatory disease is mild. These patients do not need to be even admitted, but if clinical picture is severe, then they need to be admitted. Okay. The next one is ultrasound scan. So it's mainly, especially if we are worried about the possibility of having an ectopic pregnancy or some other complication, it can help, or even acute appendicitis or tubovarian abscess or hydrosalpinx. Yes, it can show. So Doppler ultrasound, it's more useful, if, especially if we are worried about having, say, for example, ovarian torsion, like if it's unilateral pain, and if we are thinking about it can be a tubovarian abscess or is it ovarian torsion, because in ovarian torsion there is low grade fever. In tubovarian abscess there may be fever, but it may be like whenever there is abscess it's kind of swinging pyrexia, right? So but there are a lot of factors, right? But Doppler ultrasound mainly it helps us in detecting um, the ovarian torsion. And rest of yeah, it's less useful otherwise. Then we can perform a CT scan of the pelvis, if especially if it's a tubovarian abscess. Okay, but first, of course, we will always perform an ultrasound. Now, what is the general advice? It depends on the and of course swabs. Yeah, so swabs, of course, right? High vaginal swab and then intracervical swab. So of course they're very important. Okay. So, general advice depending on the severity, they may be well, but if it's severe disease, they need rest. If they are in pain, they need analgesia. Of course, they will need antibiotics. We do not need to wait for the swab results. Now, if intravenous therapy is recommended for patients with more severe clinical disease, like but these, if we have to start intravenous therapy, they need to be admitted. So, for example, if the patient has high-grade fever, we have suspicion of tubovarian abscess, and then signs of pelvic peritonitis, right? Then, if the patient had intrauterine copper device, and that may be a cause of pelvic inflammatory disease, we have to remove it, but always take a detailed history, like when was her last sexual encounter, because if we remove it now, she may become pregnant, right? An unwanted pregnancy. So yes, we have to remove it, and that IUCD, once we remove it, we have to send it for culture sensitivity. Okay. So remove IUCD, but consider risk of pregnancy if he has had unprotected intercourse in the last week. So that may be a risk. Okay. And to avoid reinfection, patients should be advised to avoid oral or genital intercourse until they and their partners have completed their treatment. We discussed this already. Current male partners of women with pelvic inflammatory disease, they should be contacted and offered health advice and screening for gonorrhea and chlamydia. The thing is, there is stigma associated with, of course, pelvic inflammatory disease and sexually transmitted infection. So in some countries, there is a proper channels. Okay, so patients are anonymized, and it's called contact tracing. Their sexual partners within the last 6 months they are traced, which means they just get a letter. Okay, and they are not told that who is the index patient, who is the person in whom it is detected. Okay, and they just may get a letter that one of your recent partners is detected with this condition, this STI, and please get tested and you need treatment. Or okay, so it's like that. It's anonymized, but in majority of countries, that system is not present. So ideally, it should be done. Then other recent sexual partners, tracing of contacts, yeah, that's called contact tracing. And since onset of symptoms is recommended, we just discussed this. Okay, now which patients to admit and which patients can be sent home? Is it outpatient or inpatient treatment? So outpatient therapy is as effective as inpatient treatment for patients with clinically mild to moderate pelvic inflammatory disease. It depends on their severity. Okay. So, if they are outpatient, we of course have to give them oral treatment for 14 days. Of course, we will give them the first ceftriaxone intramuscular injection, right? But rest, like metronidazole, will be oral. Okay. So, admission for parenteral therapy means intravenous, right? Observation, further investigation, and or possible surgical intervention should be considered in the following situations. So, if a patient has severe clinically they are not well, or a surgical emergency cannot be excluded. For example, if we are still suspicious about, oh, it may be a cyst rupture or something, or even if it's a tubovarian abscess, we have to admit them. Or initially we send the patient home, and we started treatment, but because they need to be followed up. Okay, so on follow up, or she comes back saying that it did not help her much, then we need to. Lack of response to oral therapy, clinically severe disease, presence of tubovarian abscess, intolerance to oral therapy, because especially with metronidazole, a lot of people do not like it. It causes a metallic taste. It has a very bad taste. Okay, and or well, with all antibiotics they can develop diarrhea. And if she is pregnant with pelvic inflammatory disease. Now, if they need surgical treatment, even if it's a tubovarian abscess, first they need to start antibiotics, and then they will have surgery. Okay. So laparoscopy may help early resolution of severe disease by dividing adhesions and draining pelvic abscesses, and sometimes laparotomy may be required to assess and treat clinically severe pelvic infection. It is possible to perform adhesionolysis, which means breaking the adhesions in cases of perihepatitis, but there is no evidence on whether this is superior to only using antibiotic therapy at a lot of places. So in some guidelines, the tubovarian abscess, if it is more than 5 centimeter, then it is surgically explored, and that's usually okay. So then follow-up is very important, but most patients, they are just lost to follow-up. They do not like to come back. At 72 hours is recommended. Failure to improve suggests the need for further investigation, parenteral therapy, and or surgical intervention. And further review 2 to 4 weeks after therapy is recommended. If the initial problem was gonorrhea, repeat testing should be routinely performed after 2 to 4 weeks. And if the actual problem was chlamydia, then repeat testing after 3 to 5 weeks. Okay, so this repeat testing is very important, just to make sure that that patient is now free of that STI. But even if they are treated, even if they test negative after a few weeks, there are high chances of reinfections. Okay, so these are the references I took these slides from. If you have any question, just